Hello everybody, today we will read about premature ovarian insufficiency or POI. By definition, premature ovarian insufficiency is the depletion or dysfunction of ovarian follicles with cessation of menses before age of 40 years or the loss of ovarian activity before years of age. By ACOG 2018, describe it as premature ovarian insufficiency, defined as a spectrum of declining ovarian function and reduced fecundity due to a premature decrease in initial follicle number and increase in follicle destruction or poor follicular response to gonadotropins. Now, the causes of POI, that is primary ovarian insufficiency. First, chromosomal abnormalities. The incidence of an abnormal karyotype is higher in women with primary amenorrhea than in those presenting with secondary amenorrhea. Gonadectomy should be recommended for all women with detectable Y chromosomal material. Second, chemotherapy and radiotherapy. It leads to immediate loss of ovarian function, which is termed acute ovarian failure, which may be transient. Third, fragile X syndrome. Here, it is X-linked inherited condition. It is a type of POI and a normal karyotype. Fourth, autoimmune. It is associated with other autoimmune conditions, most often adrenal, that is addition disease, thyroid, hypoparathyroidism, type 1 diabetes, etc. POI of adrenal autoimmune origin is the most frequent type observed in 60 to 80% of patients with autoimmune POI. Fifth, infections. Most common infection is mumps. Sixth, autoimmune gene mutations. Galactosemia is associated with a higher risk of developing POI. Seventh, surgery. Both ovarian surgery for endometrioma and endometriosis as a disease appear to influence age at menopause and the risks of POI. Eighth, environmental causes of POI. Smoking, alcohol, nutrition and exposure to endocrine disruptors may influence age of menopause but are not readily diagnosable causes of POI. And ninth, idiopathic. Now, clinical features. First, it may present with typical symptoms of estrogen deficiency such as vasomotor symptoms, hot flashes and night sweat and menstrual disturbances. Second, vaginal symptoms, dyspareunia and dryness. Third, sleep disturbance, mood changes, poor concentration, stiffness, dry eyes, altered urinary frequency, low libido and lack of energy. Fourth, symptoms may be transient or intermittent and may be variable in severity of spontaneous onset of POI. Fifth, may be asymptomatic. And sixth, symptoms are less likely in young women with primary amenorrhea. Now, the investigations. The diagnostic criteria of POI therefore consists of: first, amenorrhea for at least 4 months. Second, an elevated FSH level more than 25 international units per liter on 2 occasions more than 4 weeks apart. Now, the health consequences of POI. First, bone loss and fracture risks. There is risk of osteopenia, osteoporosis and fracture, especially if hypoestrogenism occurs early in life and before actual of peak bone mass. Second, cardiovascular disease risk. Women with POI have a 50% greater subsequent risk of ischemic heart disease related death compared with those who experienced menopause between the ages of 49 and 51 years. Third, cognition, mood and psychosocial functioning. Poor psychosocial functioning is explained in small part by vasomotor symptoms in this population. Fourth, risks of breast and endometrial cancer. Combined HRT does not add to the risks of cancer endometrium. The evidence suggests that Women who use or have a history of using combined hormonal contraceptives are not at increased risk of breast cancer. Fifth, fertility considerations. There is a small chance of spontaneous pregnancy. Now, treatment. Now, treatment of POI. Counseling. First, counsel the patient and her family about the compromised fertility and the need for long-term hormonal therapy. Second, psychology counseling also to be offered because of impaired self-esteem and emotional distress. Third, counsel to avoid smoking and to maintain a healthy lifestyle. Fourth, in women with fragile eggs prematuration, the relatives should be offered genetic counseling and testing. Fifth, diet should contain the recommended intake of calcium and vitamin D, and they should do weight bearing exercises to maintain the bone health. Sixth, measure blood pressure at least annually and lipid level every 5 years. Seventh, approximately 20% of adults with idiopathic POI experience hypothyroidism. Therefore, test of thyroid disease is done every 1 or 2 years. Eighth, if symptoms persist, test for diabetes mellitus, pernicious anemia, myasthenia gravis, and rheumatoid arthritis. And ninth, contraception should be offered. Now, medical management. Aim of treatment. First, replace of hormones. Second, the goals of hormone therapy is symptom relief and to support bone, cardiovascular and sexual health. Now, hormone replacement therapy. Now, indication of hormone replacement therapy in premature ovarian insufficiency. First, vasomotor symptoms. Second, HRT with early initiation is strongly recommended in POI to control future risks of cardiovascular disease. It should be continued until the average age of natural menopause. Third, genitourinary symptoms and bone health. Fourth, normalizing sexual function, that is dyspareunia. Now, treatment of premature ovarian insufficiency. In girls with absent or incomplete breast development, estrogen therapy should be initiated and increased slowly before administration of graduated progesterone doses until breast development is complete. Second, once pubertal development is complete, ongoing hormonal therapy will be necessary for long-term health. Third, transdermal, oral or occasionally transvaginal estradiol in doses of 100 microgram daily is the therapy of choice to mimic a physiologic dose range and to achieve symptomatic relief. Fourth, 17 beta estradiol is preferred to ethinyl estradiol or conjugated equine estrogen for estrogen replacement. Fifth, the additional of cyclic progesterone for 10 to 12 days each month is protective against endometrial hyperplasia and endometrial cancer, risks of unopposed estrogen. Sixth, HRT has not been found to increase risks of breast cancer before the age of natural menopause. Now, other management. Untreated POI is associated with reduced life expectancy largely due to cardiovascular disease. Reduce its risks by not smoking, taking regular exercise and maintaining a healthy weight. Second, POI is associated with reduced bone mineral density. Maintain a healthy lifestyle involving weight bearing exercise, avoidance of smoking and maintenance of normal body weight to optimize bone health. Third, measurement of bone mineral density at initial diagnosis of POI should be considered for all women, but especially when there are additional risk factors. If a diagnosis of osteoporosis is made and estrogen replacement or other therapy initiated, bone mineral density measurement should be repeated within 5 years. Now, fertility of POI. First, there is a 5 to 10% chance of spontaneous conception despite a diagnosis of POI due to occasional spontaneous resumption of ovarian function. Second, IVF with donor oocyte is often the most appropriate treatment. Third, antenatal aneuploidy screening should be based on the age of the oocyte donor. Fourth, pregnancies in women who have received radiation to the uterus and in women with Turner syndrome are at very high risk of obstetric and non-obstetric complications. Women with POI should have their blood pressure, renal function and thyroid function assessed prior to pregnancy. Sixth, these are high risk pregnancies and should be managed in high risk obstetrical units. Thank you for listening. Thank you.